is open to the public, so a warm welcome to all of you in attendance and anybody watching online. I'm Councillor Ruth Milsom. I'm the chair of this Health Scrutiny SubCommittee. Before we start, I've got a few housekeeping arrangements just to mention. Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There's no fire test planned for today. If there is an emergency evacuation, please take instruction from the council staff present. The assembly point is in Tudor Square. The meeting today is open to the public and will be streamed live and for subsequent broadcast via the council's website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the council's published policy. By entering the meeting room, you are consenting to be filmed and to the possible use of those images and sound recordings for webcasting. Can I please ask that members introduce themselves, if we go round from Laura?
Morning, my name's Laura McLean. I'm a councillor for Walkley Ward.
Morning, I'm Councillor Martin Phipps, the Councillor for City Ward and Green Spokesperson for the committee.
Good morning, my name's Dianne Hurst. I'm the elected member for Richmond Ward.
I'm Councillor Steve Ayris, Councillor for Graves Park Ward and Deputy Chair of Health Scrutiny Committee.
Sophie Thornton, Councillor for Beechiff and Greenall Ward.
Anne Whittaker, Councillor for West Ecclesfield Ward.
Lucy Davis, Chief Officer, Health Watch Sheffield. Health Watch's public voice around health and social care services.
Joanne Cooper, Democratic Services.
Deborah Glenn, Policy Officer for this committee.
Thank you. Have there been any apologies for absence today?
I've not had any.
Okay. I understand there are no items that require the exclusion of the public and press. We'll just welcome Councillor Rooney. You want to quickly introduce, sign in, and we'll introduce you in a moment, Nick. Well, you'll need to sign in on your mic. Thanks. Can we find him a name card? Just while you're dealing with the check, I'm to ask members whether they wish to declare an interest in any of the items of business on the agenda. Councillor Thornton.
Thank you. Just for the interest of caution, for item 7, I think potentially a pecuniary interest, as I'm an employee of Sheffield Men Cap and Gateway, which is a part of the consultation work, but have not been involved in any of the consultation work that's a part of the report.
Thank you. Councillor Rooney, are you fully... Okay, Councillor Rooney is here. We'll go on to the minutes of the previous meeting. The previous meeting was chaired by Councillor Ayris in December. If I could ask members who were present to approve as a correct record the minutes of that meeting. Looking for Councillor Ayris to lead.
Agreed, Chair. Yeah.
No comments on the minutes? Thank you. Okay. Item 5 is public questions and petitions. We do have one public question and Mr. Berry is present with us to ask his question. Because it relates to item 9 on the agenda, which is the palliative and end-of-life care item, we'll defer your question until that item, Mr. Berry, so that we can hear that in the context of that report, if that's okay with you. Thank you. Members' questions. This is an opportunity for members of the committee to ask questions about any items which are not on the agenda. I don't think we've had any submitted, not on this occasion. Okay, and so we reach item 7, which is the future of health services for adults with a learning disability in Sheffield. And I can see a raft of people, but I can't read your name tags because I'm so short-sighted. So if you'd like to introduce yourselves and your role, so why you've come today, and then we'll hear your report. Thank you.
Is that working? Great. I'm Richard Bulmer and I'm Head of Service for the Rehab and Specialist Services in Sheffield Health and Social Care and responsible for the Learning Disability Services on the left.
Good morning, Commissioner. My name is Alan Butcher. I'm the co-chair of the Transformation Board, which has been overseeing the transformation of the LD services.
Adam Butcher.
Morning everyone, my name is Dr Hassan Mahmood, Consultant Psychiatrist and Clinical Director for the Learning Disability Service at Sheffield Health and Social Care NHS Foundation Trust. Good to see you all.
Morning everyone, Louisa King, Head of Commissioning at South Yorkshire Integrated Care Board. So I cover mental health, learning disabilities, dementia and autism. I'm here on behalf of Heather Burns. So we did have a name tag for Heather Burns, but unfortunately she's not able to be here this morning. So you've got me.
Thank you. We'd like to hear your presentation and then members will no doubt have some questions. We've given ourselves until 11 o'clock for this item, so if we just bear that in mind as we go along. Thank you.
So I've got just a very brief presentation. We've presented the paper. I think this is the 4th time that we've been to the Health Scrutiny Committee, which I think sort of represents the journey that we've been on in Sheffield Health and Social Care Trust with Learning Disability Services. So at previous meetings we've outlined the concerns that were initially raised by the CQC over 2 years ago. We've brought to the committee the process about improvement of the learning disability services. We've brought to the committee lessons learned, we did a sort of a detailed document and detailed thoughts about lessons learned and what happened with the learning disability service. And then we've been updating progress in terms of the changes that we've made with the learning disability service in Sheffield. So just 5 things I just thought to highlight from the paper. The first one is about co-production. So this paper's, we're joined here by Adam, who's been the joint chair of the project group, who's an expert by experience. But co-production has very much driven the work that we've done in terms of developing this model. In fact, I think it's been commended by experts outside the city in terms of the work that we've done in terms of being creative, in terms of involving service users, but also making sure service users' voices are at the heart of the work that we've been doing. Secondly, I just wanted to emphasise that this is a story in terms of reinvestment, in terms of changes for learning disability services. So all the money that was previously being invested in inpatient services for learning disability has been moved into investment or into community services for learning disability. And I think that's almost unprecedented in terms of the amount of reinvestment in services for learning disability. I think there'd be quite a temptation in the system to look at actually taking money out of the system as we were closing beds. But that's presented us as a real opportunity to develop a really exciting model for learning disability services in the community going forward. And since the last time we met, we've been involved with a clinical senate. So a clinical senate is an NHS body which the Sheffield Place commissioned to work with us in terms of developing the model. But they work as a group of external experts from outside Sheffield, including clinicians, experts by experience, coming in and reviewing the work that we've done with the model. And they've commended the work we've done and have recommended that this work should carry forward with sort of some caveats which we've been able to address. And the caveats have included things such as making sure that if anybody was placed out of area, we'd have proper provision to support them out of area, to making sure that we're looking at how we invest in peer support workers in the model. So we've taken full account of that work. The next point is we're getting on with recruitment, which is one of the caveats that the clinical senate had was, would we be able to recruit into the service? But we've had over the last few years some really exciting recruitment. Hassan's joined the service's clinical director from Birmingham, bringing us expertise, but we've also recruited additional consultant time, different ways of working in terms of senior nursing input into the service, and speech and language therapy, which are already making a difference to the provision in the city. And the final point is we've been extending the work in terms of green light working. So green light working is where where needed, we involve mainstream services for mental health. So, for example, if somebody does need to be admitted to hospital, there's no reason we should be placing them in a placement out of area. We should be looking about how we can do that within city, and we've had some really excellent examples of that work going forward with that in terms of what's been happening within the city. So, hopefully that gives a flavour of the paper, and hopefully today we've got sort of a group of us who can answer any questions from you as a committee. So thank you.
I'm building on that, Richard. We didn't think this time is giving a co-production update of what's quite a flavour of some of the work we've actually done in that co-production arena. So that's impact as well. So I'm happy to take any question on the co-production side of it.
Thank you. Members, any questions? Councillor Thorne.
Thank you, Chair. Thank you for this report. It's good to see that this is taking shape and going ahead with a really good consultation, so thank you for that. I'm just wanting to ask, in terms of when we, in the event that we would have to send someone out of area for an inpatient bed, who would be then responsible for ensuring that they have continuing care post-discharge in Sheffield? Would it be the hospital that they're admitted to? Would they be expected to then refer back to the Sheffield community team, or is it Sheffield's responsibility to keep tabs and monitor that? And how would that process be then assured locally? As we don't want someone discharged, not followed up on, and then ending up in another crisis, really. So just hoping you can talk me through that process.
Thanks for your question, Councillor. If a patient is sent out of area within the experience and engagement team, what we can do is, through our liaison officers, is find out which hospital they're in, and we can actually do regular check-ins with them and to make sure that, one, settled any problems, we can raise it through Richard, Hassan, and General, and once they come back, I think it'd be able to Hassan and the team to carry on that work, I think.
CTR process as well helps as well with that, so care treatment reviews, if somebody's admitted, then that's there to help people. Care and treatment reviews are really important, so they're there for people before they're admitted to try and reduce the risk of people being admitted to a hospital, and secondly, after admission, to reduce the length of admissions as well, so that involves people already involved in that person's care. So that's ideally there to reduce the length of any admissions and to address any concerns as well.
And just to add to that, in terms of the way the model's been developed and the additional resource in the community, we'd be very much outreaching into those services, so we'd be making sure that professionals are going out there and linking in with any unit that people were admitted to. That's practice that we already have with people who are admitted out of area with mental health problems, in terms of making sure that we outreach into the services. But just in terms of emphasising, this should be an incredibly rare occurrence when we were sending somebody out of area. And if I can just give an example of sort of 3 cases, which is I think in terms of, so about when we had the unit open, people were typically being admitted to hospital for over a year, having very long periods of time in hospital. Once we closed the unit, we've had 1 or 2 people, probably about a year ago, who we did green light working with, which means they were admitted to our inpatient hospitals, and had briefer admissions, but it was still quite a long admission. And then more recently, we've had an admission where somebody had a green light admission. The service was really able to intensely enrich with them, and their admission was for a 3-week period. So I think in terms of the changes that we're having people who previously over 2 years ago, we're having the sort of length of admissions that was probably almost leading to institutionalisation in terms of the length of time. Whereas now, any admissions we're having, we've been able to make them very brief because of the team that's available and the change in emphasis in model about linking in with teams wherever they're admitted to.
Thank you for that. Just for clarity with care treatment reviews, does that sit with you then, or does it sit in the hospital that they're admitted to?
I was going to say, so it's a partnership between the ICB and Sheffield Health and Social Care Trust so we have a team in the ICB who carry out care and treatment reviews alongside partners across the city. And safe and well checks will be carried out between both teams, working together to make sure that people get the support they need.
Okay. Councillor Rooney.
Yeah, apologies for the late arrival, bus service, and apologies for the kerfuffle I made when I came in because I couldn't find my security badge. Apologies again if I've missed something that's glaringly obvious in the report, but what I can't actually see, or maybe I missed, is services at the very basic level, GP level, which is where my wife works with adults with learning disabilities, physical disabilities and challenging behaviour. And one of the biggest problems that she confronts in her daily work in terms of the health service is the inability of, for example, GPs to deal with some of the behaviours of the individuals that she looks after. It's also the case with district nurses and dentistry as well. They don't seem able to cope with, they're not geared up to cope with the sorts of challenges that those individuals pose. And as I say, if it's in here and I've missed it, I do apologise, but I can't see how that is dealt with. This seems to me to be people who have needs that are, shall we say, out of the ordinary everyday needs, you know, and I can't see anything in there that deals with that. Oh, the other thing is something I've mentioned before as well, is I remember, and Richard will remember me being on the board of the Care Trust when it was that learning disabilities was a shared service between the council. And then there was this rapid, rather unseemly, untidy divorce between the council and the Care Trust. And I'm not sure what the learning disability service looks like anymore, who runs what, where it sits, and who's responsible for what. I think some sort of, I personally would think, this is from my own knowledge more than anything, and old science sakes, as it were, I'd appreciate some sort of explanation of what service sits where, because I think just simply so that I could understand better what I'm looking at. Okay, thank you, Chair. Hope that made sense.
I'll start. Firstly, with the primary care links, it isn't about the primary care service for learning disabilities. This is the service that the remit of the service is to provide learning disability service for people with serious mental health problems alongside that. On saying that, the service, those people who are in touch with the services who fit that criteria, we would be working very closely with GPs. And again, the nature of the work, the nature of the team means that it's able to work in collaboration with GPs with that, but also in terms of those people who fit the remit of the service, that we'll be looking at their whole health provision. So that means we'll be looking at making sure that they have proper sort of health reviews in terms of all of the stuff that goes with that, because we know that people with learning disability have a propensity to die younger than people. I think it's 20 years is that age gap with that. So those people with mental health have that exasperated. So it's actually really important, the work that we're doing, that we look after people as a whole person when they're working with the system. In terms of the interface with the health and the local authority and the provisions of different parts of the service, there is still the social care is now provided by Sheffield City Council, and where we have interfaces with the local authority with that. So, and we've had, and I suppose those interfaces potentially come into the most challenge when we've got situations where we've got potentially breakdowns in placements. But the sort of systems we've got in place is when that happens, we make sure that we're working very closely with the local authority about identifying joint work that can happen with that. We've got sort of quite strong relationships with the local authority about picking up those particular issues where there's interface issues, but about say placements that are funded by Sheffield City Council, but the placement isn't working effectively, so we can go and reach into those placements and link in with the local authority. So I think that hopefully that answers the question about the changes in terms of the local authority being part of the Section 75 agreement, I think it was, and now being external to Sheffield Health and Social Care Trust. With that, is there anything else you want to add?
Yeah. In terms of working with colleagues in primary care, I've delivered talks around the STOMP agenda, which is a stopping over medication of people with learning disabilities and or autism agenda. Work very closely in my consultant psychiatrist role with colleagues within dental services as well. We think about the holistic care of people. We don't just think about the role, in terms of as a psychiatrist. It's part of the role of a psychiatrist is to work holistically with colleagues in dental, primary care. It's really important, as Richard said, we know about that essentially people with learning disability have an earlier median age of death compared to the general population. That's why the LEDA programme is there. So very important. Within the ICB, we have what was the LEDA steering group. It's now called the Physical Health Implementation Group as well. So it's really important that we think about this in a holistic manner, and we have different services within, different parts within the learning disability service. We have a range of professionals that are there to meet people's needs as a specialist learning disability service. We have psychiatrists, we have community nurses, speech and language therapists, physiotherapists, psychologists, and within the new model, in terms of learning from the LEDA programme, we're also going to have specialist dietitian as well. So we are really thinking holistically about what we need to do in the new clinical model as a specialist learning disability service. So it's not the same as the LEDA model, is it? LEDA. I talked about it briefly. Yeah. That's enough.
Building on what I said for the lead programme and that as well, one of the aspects of that one is through collaboration with council as well. We looked at the health passport as well, which is a key tool for the service that we can actually pinpoint which other services that patient or that service user engages with. So when it comes to the NDT, I'm working with colleagues from ICB, it's all listed now, so it's a lot easier for when we are doing an NDC working to pick up when we need to contact as well.
Just to add on the comms point, we are going to be, one of our next tasks is to come up with a joint engagement plan between partners, and I think your feedback's really helpful as a pointer to make sure that we clarify in our communication what this service is and where other partners fit in as well. So I've written that down to kind of make sure that we pick that up with our communication plan as well. So hopefully that makes sense.
I mean, the reason I raised it is that I think you need to start and get the basics right, so that, I mean, I was around when death by indifference and 6 lives came out, and that was because the basic GP services had failed a section of society, and they weren't delivering basic services to them. I mean, I've got, well, through my wife's work, I've got examples of doctors sending somebody with severe anxiety and learning disability to have a blood test over at Northern General. No, it doesn't work.
We can provide support around desensitisation. I know it's getting a bit technical here, but just to answer your query, around to reduce people's anxiety around having blood tests, and we have that facility within the service, and colleagues have great skills and be able to provide that service. So I think based on what you're saying and what you said as well, Louise, it's about developing our communication plan moving forward.
Councillor Ayris and then Councillor Hurst.
Yeah, just wanted to congratulate the team on the work that has been done so far. And you know, as you said at the outset, this is what the third time you've come presented to the Scrutiny Committee. Just a question about time scales. Have you got a sort of an idea of when phase 2, you know, reach the point of implementing phase 2, and also a timescale regarding the joint engagement plan? Have you got a sort of a sort of been thinking about what, you know, where that will happen?
So as I said, we've started the implementation in terms of where we're up to with the development, and I think we're hoping to have the development sort of completed by, I think it's July this year, in terms of everyone recruited into the service. That's ambitious, in terms of getting there, in terms of the recruitment, but we're onwards and setting up that piece of work. I'm sorry, the second part of the question was
the joint engagement plan.
So you want to say that, Lisa?
So we were coming to this meeting first, and I think after this meeting we'll get together. So my guess would be we would have agreed some messages within the next 4 to 6 weeks, I would have thought.
I think so.
Yeah.
Thanks for that. Thank you, Chair.
Thank you, Chair. Thank you for that presentation. It does seem like a very intense way of delivering services, but also capable of delivering much better outcomes for the individual. And it's that I wanted to focus on. I know you're only just starting to deliver in this way, but what feedback have you had so far, I think, from service users? And it seems to me that it's a good way if you can deliver services intensively, so that the individual gets to the end result that they need, where they need to be, but not have risk long stays in hospital so that they do become institutionalised. That has better outcomes all the way round, but also the potential for considerable, even though it's an intense service, considerable money saving in the round. Have you got any plans in there for assessment? Because as it rolls out, you're going to have to sell it, aren't you? So what do services think? Do you think it has a capacity for money saving? And have you got any minute reviews along the way so that you can say, look, this is what we've delivered, this is the reaction, this is the saving?
Thank you, Dianne. Quite a lot sort of done all the way through this project is kept that engagement work going. Because a few other issues that we found out is if you don't take this clientele with you, you're going to hit a brick wall. So a lot of time is through David, Hassan, and the colleagues in IT. We've got a co-production group, and I think it's works with Mencap and all that lot. So a lot of it is taking the clientele with us, but also taking the carers with them as well. Because going back to what Hassan said, a lot of it is around that holistic approach. It's a journey. It's also with stakeholders like yourselves to make sure that if we need that little bit of a jiggle, we can do. But what we'll do, that's from the co-production side, but from the other part, we'll let the colleagues come in, because they know more about the clinical side of it.
I can talk a little bit about co-production. So one of the things I really like about the co-production, I might be a bit biased, is that we're really engaging with the diverse communities in Sheffield. So I myself visited one of the voluntary sector hubs within Sheffield. And if you look within the co-production update, which my colleague has written, some of the work is really exciting. So just thinking about Mick's point about primary care, it talks about MENCAP have recruited primary care learning disability nurses engage with people across the city to raise awareness and ensure annual health checks and health action plans are in place. So lots of that co-production work's been done, and the feedback's then being incorporated into the service with a view to having action plans. So that's really, really positive. So it almost feels like a constant feedback loop, isn't it, into the service in terms of listening to people. And then taking that feedback into place. And I think also as part of the implementation plan is also a plan for evaluation about how this goes as well. And I understand the trust has a plan in terms of thinking about benefits realisation, what benefits does this have. So it's not just, well, we're doing it and that's it. It's a constant evaluation and obtaining that feedback and seeing how we're doing. And if there are any issues, then we need to adjust our response accordingly.
One thing I was also just raise the thing about the cost savings that this might realise. I think the cost savings that we'll probably realise is to the wider health system rather than to the learning disability service. Because I think what we're saying is we want this service to be a really intense community service that sort of is able to do the points I think so Mick was raising about how we're better linking in with primary care. So sort of cost improvements that that cost savings that might be made in primary care because we're better equipped to provide people's needs in the community. But also in terms of that sense of people's lives. So sort of in terms of people being able to contribute greater to society. So Adam's a great example of somebody who makes a fantastic contribution to the wider society, and that sort of getting people to a better state through their mental health being better managed will sort of manage to make sort of better contributions in terms of that side of cost savings. But we're not anticipating that this is a project that will in a year's time or 5 years' time say, well, actually we can reduce the amount of money that we're spending on learning disabilities. We want to sort of maintain that investment in community provision and just keep enhancing that offer to mean that people are using less resources in the rest of the system. It's harder to realise those benefits. So again, the benefits in terms of if we're looking after people's mental health better with learning disability, the likelihood is they're going to have less access to secondary physical health care, so things like heart disease, diabetes, all of those things will be impacted by providing better mental health care for people in this service. So that health economic gain isn't around taking money out of the service, but it's about a wider health economic gain, I think, gain for people with learning disabilities in the city.
One thing I want to add, Dianne, if that's okay, is that Adam and I have been asked to share, because we both chair the SHSC Learning Disability Transformation Board, and we're asked to share our learning at an international forum in London in April, which shows the impact that our work's been having, so it's really positive as well. I wanted to share that with you.
Thank you for that. Yes, what you said there, Richard, was what I was trying to get at, because the more you can share, the more you can the learning and the experience of the users around this intense model can be shared and the stories collected, the more you're likely to get continued investment, because the wider NHS, wider services will say, actually, yes, it's spent to save, isn't it? So I think it's well worthwhile collecting those stories and experiences of users, but also that forward, yes, because of X, Y didn't have to do. And I think it's important collecting those stories, and I would hope that would be built into future reviews.
Yeah, before and a lot of these case studies and things you talk about could actually go into our communication plan as well. So a lot of it's that whole circle approach.
That's what I wanted to hear. Thank you, Adam.
Thank you, Chair. And thank you for the report and all your work. Thinking along the same lines as Councillor Ayris around timeframes, and this is possibly a bit of a silly question from me, but I was just wondering, do you have a rough view when the changeover from Fairs Hill Rise to the new model will take place? Is that July when you're talking about hopefully being fully staffed or aiming to finish recruitment? Or would it be later on in, say, first quarter of 2025 or something, just example? And I've just got one more quick question. It's mentioned around the short stay residential model for South Yorkshire and looking for a place for that. And I was just wondering, is there any news on where that might be for South Yorkshire? Thank you.
If I take the first question in terms of so First Hill has closed in terms of the inpatient unit. So what in terms of the changes that we've been making since it closed, there's been some staff who've been moved across to the new model sort of straight away. And in terms of so we're in an evolutionary phase in terms of getting to the new model. And when I talk about July's our aim to have everybody fully recruited into the model. So in July we'd hopefully be having a model where we're working across 7 days a week with extended hours. But we're gradually increasing the provision. So, for example, we had a long waiting list for speech and language therapist, which is a really important part of the service offer. We've been able to make sort of quite considerable inroads into that by recruiting early into those posts and getting the changes happening now. So I think that the July offer, it might be ambitious to get to July in terms of everybody, just in terms of the shortages of skilled staff in terms of across the LD system. But what I would say is that the progress that we've made with that has been incredible in terms of the amount of recruitment. We've succeeded with that, but also in terms of different ways of working. So we've got new professional types, which mean that it's attractive to nurses, etc., who can do more specialist roles, but we're also attracting roles which is sort of the new types of professions that are coming into the health system at the moment. So hopefully that answers that question. The question about South Yorkshire?
In relation to your question about the South Yorkshire Wide Safe Space, that is currently mid-procurement, so it's not something we can share about publicly. But shall I make a commitment to share with Deborah when we do have some news about that, and then she can perhaps email that out to you?
Okay, good, thanks. I just wondered if you could provide some examples of where the co-production and involvement model has directly resulted in a change, or directly influenced how services are going to be delivered, or the strategy behind them. I'd just be really interested to hear some examples of that, and sort of what that co-production kind of looks like worked out in practice, and where lived experience has directly fed into a change, and also just wondering whether the reinvestment, as you said, Richard, at the start, is I don't know if you said it was unique, but certainly outstanding in the way that money's being reinvested into a completely different style of service with no loss of that funding. So you're not having to start from scratch. You kind of knew how much money you'd have up front, I guess, didn't you? And I was just wondering if that's being seen as like a peculiarity nationally, or has it kind of sparked some interest? Might this be looked at as a model that might be taken forward as something repeated elsewhere?
Thanks for your question. Right, I'll give it. So one of right at the beginning of the process, what we did is we worked in partnership with Sheffield Voices, which is one of our community advocacy partners, and through Sheffield Main Gateway as well. What we did is we hired the Hillsborough Arena and basically took it back to basics. Told service carers and that what the service is, what we do, how we do it, and all the way through the process is we've had these engagement reports, co-production reports, and it's not just with the service users. We're having an ongoing dialogue with our carers, because I think it's okay having dialogue with the service users, which I think is important, but also the carers, because a lot of the time, talking to what Councillor said around that holistic approach, so what might come through the system, but it might be the carers might need some support as well. Because a lot of them might not have a care assessment, so it's also signposting colleague them to the right support as well. So, and then it's just been like that for me. And going back to another one, and we've tried to do co-production as well, is I think Councillor Felton might understand as well with this one, is the health passport or communication passport. What we've done with that one is we also looked at that one through a separate lens, and what is that one fit for purpose? Because a lot of it was based around the acute admission to hospital. So I've been looking separately through with Hassan in how we can do that one. And then we've also had quite a lot of co-production with how we can make sure them lot are done. But I think going forward now, how the health passport and that lot is, thanks to Rio and that lot, we can make sure that piece of documentation is on the system as well. So our service, clinical colleagues, support workers can look at, oh, this is how he likes it. But that's from and I see co-production and engagement not just as a one-stop stop. I think you've got to carry on that engagement, carry on that co-production work and engagement work, just because it's key. Not in the calls or something.
I was just going to say, just have a couple of sort of very, I think Adam's talked about sort of some very tangibles there in terms of how we're better engaging with carers, how we're better engaging with service users, how that's part of our normal business, but also some very tangible things about looking at the hours we want the service to run and the feedback from carers and service users about saying actually what we want at the weekend might be very different. So I think sort of the idea of weekends, people actually want a bit of a break from some of the provisions, so actually emergency support at the weekend, but not necessarily the same level of support at the weekends. Also the hours that we want the service to run, we very natural, I suppose the professionals, we'll jump to sort of saying we want something like 8 till 8, but actually the service users saying actually the times people want it isn't necessarily early in the morning, but it's more sort of some of the support in the early evening with things. So some very tangible things like that we're continuing to listen to service users. And then the other bit about the service user care involvement is both induction and training of staff. So sort of making sure that that's part of actually our everyday induction for new staff to come in, but also the training of staff working into the system. Hassan can probably talk a bit about the expertise being shared.
Yep.
Sure. If you look at page 24, it talks about offering art and music therapy, and that's been positive with positive case examples. The STOMP agenda, which I mentioned briefly earlier on, the stopping over medication of people with learning disabilities and or autism, there's continued development of that with, again, I can't share full details, of course, in terms of confidentiality, but some positive case examples of that. One of the things when I worked in my previous role in the Midlands was to think about tailoring the STOMP agenda to the needs of people from ethnic minority communities, which was in that trust rated outstanding practice by CQC. And so when you go through First Rise, which is still open in terms of the community service, if you go through the reception, there are STOMP information leaflets available in different languages for service users of different backgrounds. So lots of good work going on, lots of work to be done, but a very exciting time for the service and hopefully for the people of Sheffield.
Can I just add to that? I think when we talk those engagement messages that I've talked about before, I think we will be looking to do some sort of you said we did kind of format or something similar to that, explaining how the co-production exercises that we did made a difference to the service model. So.
Could I just ask, just as a little add-on to that, when somebody new comes into the service, what would be the process for sort of informing them about how everything works and giving them opportunities to be part of that co-production as well, ongoing?
I think from the co-production side, because what we've got now is I think feedback is constantly going to be the key to this. And what I can do is take away and have a chat with through Louisa and our comms thing is, once they've been through treatment, what we can probably do is, do you want to carry on with the co-production work and join us in an advisory role? Because what we're trying to do as well is a lot of our service users from mental health and leaders, some of them have now actually took us up as experts by experience, and going to what some of that one could be from a policy point of view or from a paid point of view, and a lot of that one is because what we've noticed, as if they've been in hospital and that lot, sometimes they want to give back to the service that's helped them. So I think one of the key ones from my point of view is how can we energise or tap into that useful richness of pool of service users and carers who might want to actually help us on other projects and things like that. So, so that's from my production hat put on, is I'm going to carry on with that engagement work to make sure that once they've been through the system is, do you want to help out with anything else? Because it could be anything. So that's how I see it. I don't want if you me.
The other thing I'd say is we want co-production to be the core of what we're doing on an ongoing basis. So the co-production, we're not seeing it as that was a time in place and we had a problem to solve. We're seeing it actually, this is going to be an ongoing process of service user engagement and carer engagement throughout. And as new carers come in, we'll be doing proper carers assessments, working with them to make sure that they know what's around in terms of both within the service, but also our joint working with them, partners in the voluntary third sector as well. You asked a question about, the second bit of the question was just about sharing expertise on a wider place. The work we've done with the Clinical Senate, I think is worth emphasising. That's been sort of done with external people from Sheffield. So that work, I think it's published on a wider basis than just Sheffield. So that expertise can be shared there. And I think Hassan was talking around about some of the work that we've been asked to do in terms of presenting at conferences nationally, but also I think in terms of there's also learning we're doing within the trust, because I think we have various quality networks within the trust that sort of making sure that we're sort of sharing what's happening in this service across other services. So that work of co-production, etc., is shared with different services, but also the green light working. And back to Mick's point about actually learning disability should be everybody's business. It shouldn't just be the specialist business. So how are we making sure that expertise is being shared with our community mental health teams and other specialist services? And I think Hassan's probably going to be too modest to say, but Hassan's also been nominated for national awards in terms of the work he's done, which I think is about highlighting the work that we've been doing in Sheffield in terms of sort of changes to that.
Rich is very kind of you to mention that. In terms of the question or the point about when somebody enters a service and being involved at that stage, we can take that back actually, maybe thinking about co-production, people actually thinking about maybe more involved what happens at the start of the patient's journey. But what I do remember, and it's not in this paper, but it might have been in previous papers, was around something about lead professional, so that people don't have to repeat their story, because that's what people felt previously. So they had to repeat their story to different people, whereas if they have a lead professional in the new model, that means they don't have to repeat their story. So we are listening, but we'll continue to listen to people and act upon feedback. And the important thing is that the co-production steering group is part of the governance structure, so it is that continuous feedback loop. So it's not just something that's just going to stop. When the transformation is done, it's going to continue. Because we need to continue to listen to the people of Sheffield and people of diverse communities within the city.
Yeah. Just a quick comment, really. I'm really glad to see that the model includes helping people understand their medication and how to reduce it. I think that's really important. I've done a lot over the years of work in the voluntary sector where people just are given lots and lots of medication. They don't know what it's for. They're just told to keep taking it. It causes them all sorts of issues in terms of side effects, but they're told to carry on taking it. they don't get enough follow-up in terms of, you know, how they're progressing, and I think that is really, really good that the model includes this. It's really good also to see alternative therapies like music and art. And another one would be exercise. So it's really good to see that. And thank you very much for all the work that's gone into this. And congratulations for being nominated. Thank you.
Right, so just the recommendation for the committee, which I've now lost. Thanks, is that we're noting that you're at the beginning of phase 1 of implementing the model of delivery for the new Sheffield LDA service. There's an acronym in the report. I'm going to say reports with acronyms. Try to spell them out for us. So it's a positive development to better meet the needs of this population, and we have that was it, wasn't it? So we're noting the beginning of phase 1, and I think we'd like to hear back at a suitable interval. What do members think? No one's suggesting what a suitable interval might be. 12 months? We don't want to keep on making you come back, because much as we love hearing the updates, it's really brilliant work, but we don't want to keep making you come back unnecessarily. 12 months? Yeah, and then you'll be into phase 2, and we can hear about the progress made in that. I think, just to add, when you report back, I think some of the things we might be interested in, I'm just going to look for nods or otherwise. An assessment, because you'll have been further into the implementation, maybe some assessment of care quality and outcomes. So obviously we've not been able to talk about outcomes very much yet. It's been about developing the new model, and the way that the staffing recruitment has happened, and maybe a summary of any complaints and how you handle them. Lucy?
Can I suggest also sort of information on the cases where you've had to take somebody out of area, and a little bit of kind of analysis of how far they've had to go, the impact on the family and themselves, and so on.
Okay, yeah. Thanks ever so much for your time. It's been really brilliant hearing the update. Thank you.
Said sparked something. There was a directive, wasn't there, or a missive from central government some years ago saying that we should reduce to 0 the number of individuals that are outside of where they were actually from, the placements, which was a completely unrealistic one. And I'm just wondering, in terms of Sheffield, how many individuals we have that are placed outside of city, and what the plan is to get them back, and how much that is costing us each year, because it used to cost huge amounts of money, and then somebody decided that somebody in government who didn't know what they were talking about decided that should be reduced to 0 without actually coming up with a plan to do it. So I'm just sorry about that, Chair. It's just something that what Lucy said sparked a distant memory.
So a couple of things is, with learning disability, we've got nobody in inpatient care out of area at the moment. I think that's right. There's one person out of area with inpatient care in a sort of a longer term placement.
I can provide more detail. There's obviously a limit to how much detail I can provide within this, but there's one person I know at the moment.
And then the other bit of that is, which is a very different subject, I suppose, is that's talking about all out of area placements. I think there is, in terms of acute care, there is a number of people out of area with that, which I think, I'm not sure of the numbers of that at the moment, but in terms of the LD,
it's a rare exception when we're sending people out of area with LD at the moment. And it's about that multidisciplinary team working and formulation, which is key as part of that new model. It's changing the way, well, not changing, but working that way to really make sure that we're working across agencies, are using care and treatment reviews to reduce, you know, the risk of inpatient admissions. That's what it's there for. It's a national programme, transforming care, and making sure that we do absolutely everything we can as a system to reduce the number of people that are being admitted. So, you know, we've got the framework within the disability services, we've got transforming care, we've got STOMP, you know, we've got LEDA, we've got Green Light working as well. It's really about utilising all of, you know, various frameworks to make sure that people's needs are met. It's a big, you know, we're really trying our hardest to make sure that we do the right thing by the patients and the service users and all of the people in Sheffield access the service.
Thank you again. Okay. Item 8 on our agenda is an update on the adult stammering service. How is this being presented?
It's an information briefing note. The item was expected to come to here for discussion when it was intended to, when it was expected that it would be a significant variation. But as you'll see from the content of the briefing note, that's no longer the case. So nobody's coming to present. It was really just to inform members to kind of close the loop, if you like, so that members are aware of the fact that it will no longer be a significant variation and that the service will continue as it is. It could be that members would like to hear back from it and see how it's getting on, but certainly it was agreed that it would just be an information briefing note at this stage.
Thank you. Is that acceptable to everybody? So it's just that almost we've reached the end of a pathway with what this committee is doing in scrutinising this, because it's no longer a significant change, and it was decided to retain the existing model of the adult service being hosted by Sheffield Children's Hospital. So it's by way of a kind of sign-off, I think, from this subcommittee, that we don't need to look at it in respect to it being a service change anymore. Do members want to hear back again about this in the future?
Yeah, I think it will be useful. I mean, but you know, I don't think we can fit it in this municipal year in the work programme, can we? I don't think that's feasible. But at some point in the future, I think it would be helpful to, just have a sort of an update really on how it is.
I don't mind. I mean, we could have an update. I'm just thinking we always have so much to go through, and in a way we have kind of reached a natural end that the service isn't changing, which I think is really good news, and they've put in the additional safeguarding. So I'm happy just to kind of have an update if needed, but not actually a formal item on an agenda. Maybe if we pick up any information that there's any ongoing issues or something changes, of course, but I wonder if it doesn't need a formal item and we can use our time on something else. Thank you.
So I wonder whether a proposal might be that we can write formally to say that we're happy with where things have reached now, but if there's any indication that the service is struggling, we'd like to hear earlier rather than later about that.
Yeah, I agree. I think that if in any form of update, something similar to this as a briefing note would probably be sufficient, rather than having it as a formal item, unless things start to change in any sort of significant way. I would be keen if they did come back with a briefing note similarly, to see in particular the people that were benefiting from the service before this lull and how they've been engaged and supported throughout this gap whilst this decision's been made. I think that would be something that would be quite keen. That would have been the question I would have asked had they been here today. So if that could be bared in mind, and if we are asking for an update in form of a briefing note or anything like that,
Can we note that down, Joanna? So if we write back and thank them for the briefing note sent today, and so we don't need to hear back other than we'd like to hear what had happened to service users who were in the service during that lull period where the staffing was low.
Yeah, absolutely. Where their service has been disrupted, like how have they been engaged, and have they, I suppose, been prioritised in the return to service as usual as well?
Okay, have we got that early? Okay, yeah.
The one question I had, obviously I'm a new committee member, so I've not heard from the Stammering service before, was whether this is a pattern that, not a pattern, maybe it's the wrong phrase, but maybe this is is this happening elsewhere in the country, that because of low demand, stammering services have been delivered for adults within children's services, and whether they've looked at best practice to get across the country, just up for comparison. I just wondered, that would have been my question had they come today. Oh, sorry. Just that, is this a pattern that happens across the country? So is it common that because of low demand, adult stammering services are delivered within children's settings? And if so, how they sort of looked at best practice across the country, how the services are handling this issue, I guess, would have been my question had they come today. Thanks.
I think just to set that in context, one of the things that members had been concerned about when we looked at this on previous occasions was the continuity of service as someone moves from children's to adult services. That was one of the reasons we were keen to keep it as one holistic service in Sheffield, and that was reflected back and as I think probably informed the decision to keep it as one service.
It does say in the report, there's a point that says it's not, just lost it, I found it and then lost it again. A lifespan approach to service delivery isn't unusual and can be evidenced locally in Barnsley, Doncaster and Leeds, so there are obviously other places where it is happening.
Are we happy to move on from that one? Yeah. Thanks very much. Okay, so item 9 is the palliative and end-of-life care. I think we need to let our officers into the room. Take a breather for a moment. Right, after a bit of scene shifting, I think we're there. So we'd like to welcome our guests who have come to present and answer questions on this item. Would you like to introduce yourselves and tell us what your role is and why you're here today?
Oh, on the right.
You're on.
On? Hi, my name's Jane Howcroft and I work at the Integrated Care Board in Sheffield, and I'm Head of Commissioning for Long-Term Conditions and Palliative and End-of-Life Care, so I oversee this work. Louise?
Hi everyone, I'm Louise Potter. I also work with Jane and I'm the lead commissioner for palliative and end-of-life care here in Sheffield, and part of my remit has also been to work across South Yorkshire as well.
My name's Lucy Crowder and I work on the Sheffield Citywide Respect project, which is hosted by the teaching hospitals and the ICB.
Hi, I'm Hannah Weston. I'm a GP and I'm also a clinical GP advisor for the ICB and work on the Respect project.
Thank you and welcome. Have you got is there a presentation? Can everyone see the screens adequately? Yep. Okay. All right, thank you. So if you want to go ahead with your presentation and then we'll have questions. Thanks.
We'd just like to introduce our colleague Joanna Rutter as well, please. Would you like to speak?
Yeah, apologies, I don't have a microphone. My name's Joanna Rutter. I work at Sheffield City Council. I'm part of the public health team and I've been working with colleagues, particularly Louise, around the bereavement part of this presentation.
And if I may just make a couple of introductory remarks. You'll be aware that the Integrated Care Board was created through the Health and Social Care Act in the summer of 2022. And for the first time, a statutory duty was placed on the ICB to arrange for the provision of palliative and end-of-life care. That doesn't sound like a big deal, but actually it is. And it's really focused the minds of people in the ICB. And NHS England has given us quite a lot of guidance of things that they expect us to do. And one of those things is that we have a strategy, which is sort of guiding principles for our work. And because palliative and end-of-life care is such a huge topic and touches so many people and their families and friends and so many health and social care staff, it can feel like this is a huge beast, where do we start? So that's part of the purpose of the strategy, to help us make the most of the time and the talents that we have. But I'm going to pass to Louise. She hasn't written it on her own, but she has been the main author, so she is the expert in it. Thank you.
Okay, so is someone controlling this? Okay, great, thank you. So what I wanted to do is just explain to you some kind of the background to the work that we've done and kind of what does this mean for Sheffield. In order to do that, what we've done is work with partners and with people with lived experience to create a vision. So this is our vision for South Yorkshire. It's to ensure that the people of South Yorkshire living with life-limiting illnesses, no, it doesn't say palliative care here, and there's a reason why it does say palliative care, palliative needs, with life-limiting illness experience the best possible care in the last years, months and days of life, and that the bereaved continue to receive the support they need after death. So it's quite all-encompassing, and the reason it doesn't say palliative is actually based on the feedback that we've had from the public, because not necessarily everybody understands what the word palliative is. For many people, it's that last few days of life. As actually what we're talking about here is people who are unfortunately towards the end of their life, and what the work we're doing is to make sure that those following diagnosis, that people get the best support and care that they need, and their family get that journey as well. So that's our vision, and like I say, that's been through extensive kind of consultation. Why do we need a strategy? There's lots of reasons why we need a strategy. It's outlined in the actual strategy itself, but this is kind of for everybody. It's all age. It's not just old people. We know that there are young people that do die, unfortunately, as well. So this is one of the key changes that's happened with the national duty. It's an all-age strategy. So we want to make sure that everyone has access to the health and social care to support them with the illness that can't be cured when they're nearing the end of life, and it's all age. What we've done, and I will go on to this in much more detail, but just fleetingly to say that we have worked with Lucy and across South Yorkshire to hear the patient and the family's experiences of palliative and end-of-life care. This has been done using best practice. We've consulted with professionals across the whole region, and we, in order to build up what questions we wanted to ask, and we've tested those out, as Lucy can testify in the report that's been published. The key things that we've had and which has informed this strategy is that the system's difficult to navigate. And one of the things I would say is that when we've worked with the University of Sheffield and had lots of people who've gone through that end-of-life care experience in a room, we've asked people to kind of plot what happened and which services did you work with and how long did you work and did these services interact in your journey. And the average was generally 14 plus services at any one time. You've got your GP, you've got your social care, you've got your carer support service, you might have voluntary sector, you've got your faith service, you've got your pharmacy. The list is endless, and that's why when we say it's not just a one organisation that can solve this problem, actually it is wide and a much wider spread than that. But it does mean there's lots of things that sometimes, unfortunately, the burden is presented to the family. Who do we talk to, and when do we talk to? And I don't know when that person's going to come through the door, and if so, I don't know whether it's going to be the same person that I saw yesterday. So how do we kind of work within a system that actually is quite difficult to navigate? One of the key things is about identification. So it's really tricky, and Hannah probably is testimony here really, but it's difficult to sometimes know when someone is dying. And the more health inequalities you may have, the more challenging that might be, unfortunately. So like, for example, if you're homeless, it's more difficult to identify whether that person is towards the end of their life, or if there are things that can happen to prolong that life, and how do we identify that? So that's just a little small example. But what we do know is that if you are identified, you can have conversations, you can have a plan in place. Not everybody does want to have this, but we can get those things in place if need be, and we can have the right conversations at the right time, and your thoughts and wishes can be heard. If you don't, you're more likely to go to A&E, you're more likely to phone 111, you're more likely to be admitted to hospital, and the more health inequalities you have, the more likely that is to happen. So what we've got is lots of evidence and people's experiences that kind of support that. If we can identify people sooner, that would be great. And one of the things, if just to throw in a little bit of data there, one of the things we do know is that Sheffield is towards the lower end in terms of identification. And so we want to push that to become the national average and actually stretch ourselves and learn from other areas. It's a system where some people sometimes have limited choice. So where you live in Sheffield might mean you have a different access to some services than others. If you want to receive care at a particular time of day, that, in some cases, depending on your personal circumstances, that might be particularly challenging, particularly when we look at children and young people. From the feedback that we've had on the Health Watch survey, we've got particular issues coming out in terms of pain management and access to care at the right time, who to speak to in the middle of the night, how to get discharged on a Friday, and kind of what happens within the community services. So there's a raft of stuff there. We know that carers feel uninformed. If you search palliative and end-of-life care in Sheffield, nothing much comes up, if truth be known. You might get something about the Cavendish Centre. You might get some information about St Luke's. It doesn't say this is the information and this is who you need to contact with. And that's something we really do want to change. And people don't know where to go for guidance. And we have heard that when you hear the diagnosis, both the person and their family members, it's a journey that you go through, and you might have to hear that diagnosis and have the conversations multiple times to actually get to a point where you understand what actually is really happening to you, and you're in a position to ask maybe the questions that you want to answer. So this is real key. And these are just as we've got a 75-page report. It's an amazing report, but these are just some of the things that are gleaning through. But hopefully all the priorities that we've outlined in the strategy will start to address some of the things that that's been raised. quickly moving on. We need a future-proof system. The population is growing. We have slightly different demographics here in Sheffield. We are becoming an even more diverse city than what we were before, and we understand, obviously, the financial constraints of multiple organisations across the board, not just our own organisation that I'm representing here today. I've touched on health inequalities. We want the NHS England talk about excess, quality and sustainability, and so what we need is equity to up through all those things. We've talked about the duties in the paper that I've sent. Health Watch findings, have I missed a bit? Sorry. What's the role of the ICB? I've not got that bit printed off.
I don't think that bit's so interesting.
I don't think that's interesting. We can talk through that
You
if
can have
people
that in the
really
slides.
want to.
Cut to the meat.
Yeah, so the Health Watch findings, I've probably summarised it much more actually here, but the key things that Health Watch have recommended is improved information, not just for the public but also for professionals. What we do know, we got 85 people, professionals in a room at the same time, and some people had never met. They knew these services existed, and you're trying to navigate that system. So how can our public navigate that system if our professionals know kind of what everybody's doing, but actually has never met? So we're really wanting to kind of do that from a public front, but also from a professional front. I'm just trying to think. Lots of community support. There are issues with capacity and there are issues with access. So how do we get people home and discharged from hospital when they want to die at home? And that's something that our organisation grapples with every day. And so we want to improve that. Advanced care planning, having the right conversation at the right time, having the professionals trained in having those conversations. Yeah, I think I've kind of mentioned the things there. The cross-cutting themes that have come through is all about access to services, information, compassion and understanding. We know there's excellent practice out there, but we also know there's areas that we need to improve on as well. Quality of care. We do the Care Quality Commission. You know, we know what our providers are doing. We know there are audits taking place elsewhere. But, you know, we want to kind of make sure that we're doing that across the whole patch. Equity, I've talked about, and support for carers as well, and the right information. In terms of how we're going to do this, we've got a set of principles. We're not starting from scratch. I really do think we need to say that. We have got some excellent services out there, and we've got some excellent good practice. And we want to build on the good work that's already happening. And I say South Yorkshire, in Sheffield as well. We want to build a system that reduces unwarranted variation. We know that if you are... A lot is talked about cancer. When we talk about cancer, it's all about waiting times. What we're talking about here is not about the waits to kind of diagnosis. Actually, it's about what that system is if you are diagnosed and become terminal. But what we do know is that if you're dementia, you might not be diagnosed or identified. Respiratory, again, you might not be having the end-of-life conversations. So there's variation in terms of what condition you have as to whether you have these or may have these conversations as soon as what they ought to be happening. There's variation across communities, variation in terms of age and geography as well, where services are. We want to continue listening to the needs of our public and hearing that patient voice, and there are opportunities to be involved in that. Seek opportunities to transform services. So it's not just about getting more money, it's about using the money we have wiser. I'm sure you're familiar with that. And it's about stimulating partners, getting partners in the same room at the same time and having those collaborative conversations about how do we navigate this together? Because you're doing that, you're doing that, you're doing that. How are you talking and how can we can improve that? In terms of the actual strategy itself and what we want to achieve, it's based on what's called the Ambitions Framework for Palliative and End-of-Life Care. It's a national document, and it's actually a document that is overseen by a number of over 40 kind of national organisations such as Hospice UK, Macmillan, you name it, those people around the table. And it's kind of the meeting is actually co-chaired by NHS England. These are what we kind of benchmark ourselves against, and when talking to professionals and kind of talking to the public, this is what people are familiar with and will become familiar with, and this is how we're going to structure the actual document and what we've had. I won't go through them. You've got the report. We want to achieve our vision. So what does this mean? Because what I haven't done in the report is say what we want to do. And this is what I want to say. What we want to do is we want to work with partners, which includes primary care, acute trusts and hospices, but it does include the voluntary sector here as well, to ensure good quality, personalised, integrated community care. There's a lot you can talk about. I can't do justice for it today, but ultimately seamless. It's all about what you want and your family want, and kind of seamless end-to-end kind of support from start to finish. We want minimum standards of what people should expect, and this is across the whole piece. So there are various different standards out there. What we want to do is champion what should our standards of care mean. So what should, as a minimum, people expect across the whole of South Yorkshire and here in Sheffield. We want to create more information for the public and professionals. We've put, for example, a website. It's the classic one, but actually there isn't one at the moment. So it's a start for 10, but actually we want to work with our public to actually find out from them what information they need and in what format. And the Health Watch survey has given us some rich intelligence to actually start informing those conversations. We want to co-design our system. We're going to have a panel of people with lived experience that are going to support us along the way. So within our governance structure, we've now got an opportunity to work with members of the public to kind of, who have got experience of the system, to kind of co-design our kind of services. We want to increase early identification. There are lots of different tools. There are IT solutions. It's a very clinical kind of way, but actually part of it, and some of those tools are what can be used actually in the community. I could use it with my grandpa tomorrow, who's 98 and lives in Rotherham. It's something that is quite easy to do, and it would actually, if we can talk to the public, we can actually, it's not just about talking to professionals here and upskilling them. Focus on community improvement. We want to improve the quality of respect. I'm not going to talk about respect now because we're going to talk about that in a little bit. And we want to introduce a clinical and professional reference group where we get clinicians and interested professionals around the table and talk about what pain management should be, and talk about what pathways, and talk about the fact that people are getting and having better outcomes from cancer. So when we get discharged from Weston Park, actually what does that mean for the GP who receives that, and actually educating the GPs on how to navigate that system. We're starting actually a programme which Hannah has helped to work with St Luke's, where we're actually going to be training primary care and professionals working in the community on literally a 101 on how to do palliative and end-of-life care. So that's just an example of kind of how this is already living and breathing and what we're doing. What do we want to achieve? It's like, okay, how do we measure it? This is the question. We know where we are now, and ideally we want to get to this. So we want to improve the number of people identified. We want to reduce unplanned hospital admissions. We want to reduce unnecessary A&E appointment attendances. But where that happens, we want to make that a better experience. We want to continue and hear and improve what people are saying about their experiences. We want to increase the number of people that do have an advanced care plan here in Sheffield. And we want to ensure that people receive good symptom control, the physical comfort and emotional, psychological and spiritual support in wherever they receive that care. What we do know is a lot of people want to die at home, and for some that is a possibility, but for others it isn't. And for some reason, sometimes it's literally the pure logistics of where their house is and how big their house is and whether it's on the top floor of a flat and they've got space. So there's practicalities there. But then there's also sometimes, for some whatever reason, there's medical reasons as to why they can't be at home. But what we do know, and the survey's shown, is that sometimes people haven't been able to die where they want, and that's where there's an opportunity. That's what we want to kind of work on to improve it. So where people want to die, hopefully, where possible, that can happen. that means there's a lot of work. We can't solve these things overnight. I'm going to skip through the next 2 slides if that's okay. So I'm not going to do the table because the table's in. In terms of next steps, it's just a little bit of a sketched outline. We are still in the consultation kind of feedback kind of period. In light of today, I extended that period. You can feedback your comments online tomorrow, follow the link. I'll leave it open till Monday just to give you a little bit more time if this starts kind of those thoughts processes going. Alongside updating the strategy, we will start developing an action plan. It's not just me in a dark room. We will do this collaboratively. Throughout February, I have my palliative and end-of-life care South Yorkshire-wide board, and we will be taking the updated strategy to that board for them to ratify and sign off, with a view of then that taking it on a bit of a roadshow. We're going to go to the Health and Wellbeing Board. We will be going to across all the different places, and we will intend to obviously go to the Integrated Care System Board as well.
Can I say something about them? So the strategic board that Louise is mentioning that we're taking this to for sign-off, it's a South Yorkshire-wide board, but it's chaired by Emma Latimer, who's the Executive Place Director in Sheffield at the ICB, because she's the senior responsible owner for palliative and end-of-life care. So we're really fortunate to have her because she's really passionate about this, and she's got a lot of background in that area from her work in East Yorkshire. But there are lots of other people who sit at that board from across South Yorkshire, from public health, from social care. Alexis Chappell sits on the board, and we have a number of GPs and people who represent the trusts and the hospices, the ambulance service, and the group of people with lived experience is a sort of support group for that group to kind of guide and govern their work. If you know of anyone, or if indeed yourself have got experience of end-of-life care or caring for someone or someone that you know and you would like to contribute and be involved, we would love to hear from you. And also I would like to say that if you'd like to contribute your comments on the strategy, don't hold back and write what you think we might want to hear. We've had some incredibly thoughtful and thought-provoking comments from people, and we will be changing the strategy in the light of what we've said. So some people have said, you know, your language is wrong, or you've not thought about this particular group, or it's very, very clinically focused. Now, it is a strategy that governs the work of healthcare, but that doesn't mean that it needs to be written in super clinical language. So we would love to hear from you, that is genuine. And just to say as well that the action plan that will drop out a bit for Sheffield is very much going to be governed and guided by what people told us through the Health Watch survey. They've almost given us our to-do list for the next 5 years. Of course, we are hampered by capacity. There are only so many of us and by funds. However, the people who are here, we're the tip of the iceberg of people who are working on these issues right across Sheffield every day. There's an army of people who are working to make these things better. What I should have said at the beginning, and I'm really sorry, is that Joanna can only be with us for part of the time. And so I was wondering if, with your kind permission, we could take the bereavement bit next while she's still here.
Yeah, that's absolutely fine. When do you need to go?
I need to go at 10 to.
Just what? Let's sit here.
Our intention was to go through all 3 parts of why we're here today and then field all questions at the end if people are all right with that. But if you have got any pertinent bereavement questions, we'll field them. Yeah, is that all right? So do you want me to do this? Right then. So if we scoot through to the bereavement part, it's part 3 on the presentation, probably about another 7 slides further on from where you are now. So the bereavement, palliative and end-of-life care, this just gives you a bit of a background to what we've been doing. So I will go through my presentation because there's so much we could tell you. But there's a bereavement strategy in Sheffield. What I need to explain to you is that the bereavement strategy is different to the bereavement strategy you may have heard of that is currently kind of being consulted on by the council in terms of funeral plots, etc. So there was actually a bereavement support strategy, is the language we're going to be using, which Joe actually was involved in back in 2021. And this came back on the back of COVID, when people were experiencing deaths of family members and they couldn't meet them in hospital, and they were, and there were lots of chaos happening. We've all been there, and it impacted on people's bereavement and how they bereaved. So what the strategy identified was that there were gaps in the service provision that we had here in Sheffield. So there was gaps in regarding Tier 2 service, or short-term brief interventions, counselling services, that mental health, actual structured counselling, therapy services. And then there was an opportunity here to provide some brief intervention training to actual voluntary sector professionals who were working and engaging with people who were bereaved but didn't necessarily have the skills or the training to actually start those conversations. So the work we did was to commission. We funded crews, mind and faith, star, stroke, diversity, and we also funded some education for professionals, which were provided in tandem with between St Luke's and Mind. It was joint commissioning between what was Sheffield CCG at the time and Sheffield City Council, which is why both myself and Joe are here. It's a project that we've led from start to finish at the point where we started to commission these services. I was new as of 2 years ago, so I kind of came in at the point where we were commissioning. What we're here for and the journey we're on is that this is one-off piece of funding. Okay, there was no funding before and there's no planned funding going forward. The services all end in March 2023, March, May and September, so all those 3 services by the end of September will have ended. The training was one-off and has been and gone. So there's no funding from each other organisation, there's no budget going forward as yet. And what we have in the meantime is the new statutory duty that we've just explained to you, which it actually does include about, and our vision that talks about we want care for those that are bereaved after death. There's also duties within the council to make sure people are supported as well, and Joe's work extends into the bereavement and those that experience quite traumatic kind of deaths. So that's where we are. What we know and what we've learned a heck of a lot, if I'm perfectly honest. We estimate that around 10% of those that are bereaved in Sheffield, so this is just under 5,000 people, will actually have their health affected by bereavement and actually would benefit from this type of support. What we've had over the last couple of years is over 2,500 people, adults and children, young people, so it's all age, who've benefited from one of the services that I've outlined. Waiting times have reduced significantly, but they're now starting to increase as more people become aware of these services. We know that there's good success ratings. We've got excellent case studies, both from professionals and from those experiencing the services. Where there are negative comments, it's in relation to waiting times, and I think that's one of the reasons we were here, because people had had issues accessing one of the services, and limitations around actually how many sessions they could have with a counsellor, which isn't ideal, but we had a limited budget, and it was kind of best practice shows we've got 6 weeks, but actually we can do what we can in that 6 weeks, and actually the model promoted was we will then segue them and help them support access mental health services further into the system. We've identified a continued need for these services. Why this bereavement? Most people in the general public, bereavement's a normal experience. It's not nice, and you can grieve, and in conversations with family members, just time for some people can help. But what we do know is there's a particular need for health provision. And this generally is due to people having multiple deaths, quite often in a short period of time. People having a complex death. From the Health Watch survey, complex death might be they didn't have a good palliative and end-of-life care experience. And people have shared that intelligence with us. Following a poor, with a history of trauma. So if people have got a history of trauma, sometimes that comes to light when someone dies. And sometimes people have never talked about their grief, but actually something happens and it kicks off that. So for some, it's their dog dying, actually, and it actually spikes up something that happened in their past a few years ago where people may not have actually addressed that grief at the time.
Louise, I'm going to just, because I'm aware there's 10 minutes before Joanna needs to go, I'm just going to make sure we've got enough time for people to ask questions, if that's all right.
Yes. Shall I quickly just do it in a minute, or do you want to ask questions?
Can we skip to questions just to make sure we don't run out of time? Is that all right? Yeah. Thank you.
If I can just make a few comments before we open for questions, Chair, if that's okay. I think Louise touched on it in the start of the presentation. There's a particular challenge around bereavement. The strategy that we referred to that we developed in 2021 was very much in response to COVID and the particular issues we were, as public health specialists, expecting in terms of excess deaths, so increased demand in the city, the social restrictions that were preventing people from accessing normal routes of support through family and friends. And so we were able to fund these services out of those kind of COVID recovery monies and public health monies and latterly ICB monies. But what the strategy really shone a light on was the fact that general bereavement support prior to the pandemic and during was quite underserved, to be honest, in Sheffield. There was some really excellent provision that was quite specific and quite niche in response to particular kinds of deaths. So you will see some quite specific palliative support or cancer support or national support where there's been a death of a child, and I commission specific bereavement support around supporting people after a death by suicide. But what the development of the strategy and the process that we went through really shone that there was a real need for more general bereavement support in Sheffield. Now that, as Louise has alluded to, bereavement is not a mental health illness. It's not a pathology. It doesn't sit with mental health services. It doesn't just sit with the council either. There's a real system issue about where a bereavement strategy and where bereavement support sits in terms of our system. And I think as well as obviously being available to answer any questions about what we've delivered in the light of that initial strategy, I think we'd really appreciate some support, perhaps some guidance or insight from this scrutiny committee as well about how we can address that particular point around governance and ownership for what is our offer for people in Sheffield who are bereaved, who need a bit of extra support from a service. Thank you. I hope that's okay, Louise.
Of course.
Thank you. I'm really keen that we're able to address the issue of the funding running out and what the next steps are. So we could delve into all the detail of how the service runs and what you've commissioned previously, but it's in your report, and I think we can understand that. If members are happy, I'd like us to address this issue of the funding running out and what happens next. You know, it's a bit of a cliff edge, isn't it, really? And I just want to start by highlighting that I did a tiny bit of Googling around this and read the Sue Ryder report on bereavement in the workplace, grief in the workplace specifically, and the impacts that has. And in terms, if we're talking about funding and the fact that funding is being withdrawn for this, it makes no sense whatsoever. And I don't know how this message can be got higher up the food chain here, and I know it's not your fault locally, and you wouldn't withdraw the funding if you had a choice. But this makes no economic sense at all. So just purely thinking about numbers, and this isn't where I'm comfortable just speaking about numbers, because this is about compassion and people's lives and well-being and healthy lives and ability to be resilient. But if we're talking about money, the Sue Ryder report says it costs 23 billion a year in lost gross value added through the workplace economy, and costs the UK Treasury an estimated 8 billion in reduced tax revenues, that the number of days people take off work associated with grief. So it makes no economic sense whatsoever. So for me, that's the starting point of, you know, where you're at now and the fact that these services are facing withdrawal or collapse in Sheffield. So I'll stick that out there and just say that's the point. I think that ought to be taken into account, and however that can be fought nationally to try and gain some funding from somewhere, I'll open it to members.
Thank you, Chair. I'm just thinking about funding. Do you know how much the current bereavement service that we're running costs to run on a, say, annual basis, or how much the grant was for and how many years that was over to run the services?
So Cruise, we fund them £97,000 a year. Faith Star receive 47, and 75 goes to Mind. 1,000, that is.
And I think that's just the services that we commissioned in response to the development of the bereavement strategy. There are other bereavement offers in the city. I mean, I spend about £40,000 a year on the Amparo service supporting bereavement by suicide across the South Yorkshire footprint. So there are other bereavement offers, but specifically that were commissioned in relation to this strategy.
And is that a cost share between the council and the NHS? Oh, where did the grant go to, I guess, is what I was wondering.
Well, ICB commission on behalf, basically. So some of the money came from COVID recovery money, some came from public health reserves, and then latterly to fund a year 2 for Cruise, that came from the ICB. So it's been shared. The initial strategy was developed as part of Sheffield Psychology Board, which had all partners on it as part of the COVID response.
Sorry if this question sends us off in a different direction, but it's in my head at the moment. Do we have an agreed or renewed policy in terms of do not resuscitate? And the reason I'm bringing that up.
We're coming on to that as another part of the report.
Okay.
Thanks,
Sorry, premature.
Sorry, mine was more of a comment than a question, an observation. I happen to, wearing another hat, I chair the Board of Trustees of the Hope South Yorkshire charity that deal with bereaved from fire, water and road traffic accidents. And I've been doing that for quite some time now, for several years now. And the issue that's always been there is the capacity to do things, and that is tied in with the funding for voluntary sector organisations. But they play a sort of a unique role in actual fact, but they rely on external funding. And so it's interesting to hear that the bereavement the network that is ongoing. But I'm just wondering how much that is, how much the network is put out there, basically, so that people are referred to the right, I'm talking more or less about VS sector, so VCF sector. So I'm just wondering just how much is it still a problem in signposting people to the right organisation?
There's many ways I could answer this actually, but one of the great things that Cruise has done with the money that they've received is actually build the number of agencies and sectors they're actually working with. So Cruise actually are almost a little bit of a gateway to actually directing people to the right place. When we started this project 2 years ago, Cruise, to be honest, was probably very a middle-class kind of organisation. That was their kind of profile of their very white people that they were working with. Using this money, they now offer services in very deprived areas of Sheffield as well. It's not perfect, nothing's ever perfect, but actually what they've done is they've increased the capacity and they've brought on volunteers that represent the communities in which they're working with as well. It'll never be ideal, but we're starting on that journey, and what we want is to try and continue that journey and plug them into the right networks. So your organisation hopefully can plug into crews and they can send them off. The other thing what we do have is we have a bereavement collaborative. So we haven't mentioned St Luke's. St Luke's do provide bereavement services for people that go through their services. What they're part of this collaborative, and they work with a host of organisations, not just those that we fund, to make sure that everyone gets the right information. There's more we could do. If I'm perfectly honest, if the capacity was there, we could promote them even more. What actually is holding us back is actually, even though I'm asking for and saying, give us this money, not to you, but we could do with more capacity, we could do with more funding, and then we could promote it wider.
Thank you. Thank you for this. I think it's something that I've been wanting to come to this committee and to have a actual look at what's ongoing and the good work that you've been doing. I was bereaved 8 years ago. I lost my dad 8 years ago, and I think something that I experienced throughout that is that difficulty in figuring out where things are and how to access it. And I think a big part of people accessing service is the comms that comes with that. So I'm really pleased to see that you're putting those things on a website that is easily accessible, to have that information all in one place. As you mentioned, there's so many stakeholders involved in all of this, and as there should be, because it's a whole conversation across everything. But making sure that information is accessible in one place. If someone's just having a quick look online, or just wanting to ask someone about it at a pharmacy or anything like that, it's really important. So then something else that you touched on is that death is an everyday conversation. I think I really struggled because it was just not something that we talked about at all. And when it did happen, although it was expected, it had been a long, ongoing illness, and it hit me like an absolute truck because we hadn't talked about it. So it's incredibly important that we do actually talk about that, because we've got such a big old British modestness about it, don't we? It's quite taboo to talk about, but it is something that affects us all at some point or another, and we do need to talk about it a lot more. I have a couple of questions based off of that, and also just other experiences with, I think when people are receiving their diagnosis, a lot of the time they'll have multiple different scans, different appointments, different treatment plans, they'll see different people. And medical language is quite hard to decode, and I know that it can cause a lot of frustration for people involved in that and for their carers, where although from a medical point of view they'll be saying the same thing, but they'll be using different words to explain a condition or what what's coming up in a scan or something like that, and I think that can cause quite a lot of confusion for people. Looking at actually where can people go to decode some of that language, I think is quite important. And also just looking at people who who live a slightly different life. If as a university student, you are at quite high risk of not having continuity of care. And I know of people that have not just bereavement services, but have been on waiting lists, and then they've had to change their address to their university address for whatever reason, and then been told that they can't access that service anymore. So is that something that is on your radar, and what kind of work would be ongoing to ensure that there's that continuity of service? I know a lot of that comes in partnerships with other organisations across the country as well, but we don't want people to drop off a list or accessing services when they really need it, just because they've gone to do a half term or something away. So yeah, those are some of the issues that I thought I'd raise for you.
That's really helpful, thank you. I've noted them.
Sophie, thank you for saying about your personal experience. I know you were really keen that we brought this to the committee, so thank you ever so much. And I think there's a wider discussion, and we've run out of time really for it today. So I'd like to propose that we've got a couple of workshop sessions still earmarked before the end of this council year. So can I propose that we pick up more of this conversation in a workshop setting, so that we can complete the discussion, because I think this is it's left dangling a bit today, isn't it? I mean, the thought of the funding stopping and these extended services that you've commissioned, which seem so important for reaching into particular parts of the community, that the thought that they're going to end is pretty shocking, really. So I'm sure we'll all be putting our minds to creative ways that funding might be found. Sadly, it can't just be magicked up from the council because we're in a similar position to you. But I'm sure members will be putting their minds to that creatively. I wonder whether you've approached businesses locally to bring them into the fold. Is just one thought that it's something that affects the workplace and efficiency and productivity in the workplace, and it's the business of businesses to take care of employees. It's in their own interest and people's interest. So that's my contribution to a bit of creative thinking. But if members are happy, shall we defer the rest of this discussion and let Joanna go and fix a workshop session to pick more of this up? Okay. Thanks ever so much for your time, Joanna. We've got the respect part of your report here. I'd like to bring in our member of the public who's come along today at this point so Dave Berry has kindly come along in person and sat through the whole of our meeting so far, so very grateful that you've sat with such patience and you've got a question around respect and do not attempt to resuscitate.
Yes, Chair, thank you for allowing me to attend. I have a detailed question on the respect process, but also the palliative care report has also thrown up a much broader question, really, that I'd just like to pose to the committee. I suppose the detailed question is really thrown up by the personal experience of one person at a Sheffield hospital and the DNR process and the respect process. And I suppose the second question is really around one of the recommendations here, but I suppose the personal experience is also coloured by discussions with workers in the care sector and people working in elderly care in the NHS, and also by listening to some of the COVID inquiry, where the attitude towards certain parts of the population, whether they're elderly or people with disability, was that these people have had their innings, so it was probably time for them to go, which may be reflected in some national policy. I suppose the individual question on, I'm not quite clear whether DNR is being superseded by the respect process, but the personal experience of the individual, his wife was taken to hospital. He was asked or recommended that he agree to a do not resuscitate for his wife, even though in his point of view, you know, although she was towards the late 70s, she was still active in work and academia. He didn't feel properly consulted about the DNR process, but then when she was discharged from hospital, she returned home with a respect letter in which he hadn't been consulted at all. So I suppose the detailed question is really, and it may come out in the presentation, and I'd welcome a written reply on this really, about how is the participation of the patient and their family to be reflected and evidenced in the process. So that's really the detailed question. I suppose the broader question for the committee, and they may want to revisit it, and I hope they will do an audit on the respect process at some stage. I suppose the broader question is, one of the recommendations in the report is about introduce a project to maximise the use of personalised healthcare budgets. And in the preamble to the report, it talks about health inequalities. All the evidence about personalised budgets in public services, and actually they've led to greater inequality, whether it's in the nursery provision, whether it's in provision for people with disabilities, or even in the elderly care sector. You know, all it's merely done is monetise societal differences into something that we can quantify. So I hope the committee may take an opportunity at a future date to look how the idea of personalised budgets is going to be introduced here and how the evidence to support it is carried through. Thank you, Chair.
Are you happy to address the answers to Mr. Berry's points within your what will now need to be fairly brief introduction to respect. Is that okay?
Indeed, and I'm going to hand you over to Lucy and Hannah to do so.
We just need to go back to the slides that are section number 2, please.
Yeah, that's great. Yes, so hopefully we will address some of the points you raised, Mr. Berry, within the presentation, but we can clarify anything else afterwards as well. So some of you may know something about respect, some of you may know nothing because it's quite new. It is an acronym. It stands for Recommended Summary Plan for Emergency Care and Treatment. It's something that was developed over 2 years by the Resuscitation Council, the Resus Council, with lots of different people involved, service users and many people. And it did replace DNA CPR forms in Sheffield as of the 2nd of May last year. So, yeah, in relation to that, it has superseded the DNA CPR forms. That being said, they are still in circulation with individuals who may already have one. And we'll discuss why they have replaced them as well. The concept of respect is to create more of a personalised recommendation for individuals in regards to their clinical care in emergency situations specifically. So I see it that it forms, part of the advanced care plan of an individual. And anyone might have a respect plan. There is increasing relevance if someone has a long-term health condition or is approaching the end of their life, but any individual may have a respect plan following discussion with their clinician. And it does include the resuscitation decision, and we will have a look at an example of a plan, but it also includes other recommendations, what may or may not be suitable for an individual. So in terms of people may have more experience of DNA CPR forms, which was traditionally the sort of the red and white forms that an individual may have had. We know that they were often sort of poorly individualised and poorly understood. They just had the resuscitation decision on them, which with a DNA CPR form was that an individual was not for resuscitation should their heart stop of natural causes. Important comparison with respect is that an individual may have a respect plan that is for resuscitations. So it's not just to say someone is not for resuscitation. We know that there was lots of issues with DNA CPR forms, particularly they were highlighted in the COVID-19 pandemic, where there was blanket rollouts, and the CQC were well aware, and it was well highlighted in the media that obviously that was not acceptable, and a new process was needed. I think DNA CPR forms were often misunderstood as well. Individuals often felt that it meant that an individual would receive no other care. Things like antibiotics or treatments of other conditions. So I think, the respect plan hopefully improves some of those misunderstandings. Just to mention, they are both not legally binding documents. I'm not, some people are aware of that, some people aren't. They are recommendations, both of the documents. That's in comparison to something like an advance directive to refuse treatment, which you may also be aware of, but that in comparison would be a legally binding document. So if we just move on. So the main aims of respect is to put the individual at the centre of that conversation, is achieve a shared understanding between the clinician and the patient and their family, and to focus on things that may be suitable for that patient and may not be suitable. So it's not just about not withholding care or treatments, it's about what is suitable for them as well. And the resuscitation decision does form part of the plan, but it's much bigger than that, and it might be easier when we have a look at an example of a plan. And the idea that it's recognised across all healthcare settings. 80% of the UK are now using respect, so it should be more of a nationalised document. Just to have a look at a respect plan, I'm not sure if any of you have seen one before, but it is a 2-page document. The traditional colours are purple and white, and this is version 3 of the form from the Resuscitation Council. And there may be black and white forms in circulation, and that is purely printer-wise. We don't have a colour printer, for example, and they are both acceptable forms. I'm not going to go through the form every line, but it involves the patient's details, a little bit about their health and circumstances and their personal circumstances, who they live with, what their main health diagnoses are. There's a section about their preferences for care, so what matters to the individual and what they may want to avoid or what they may fear. So obviously that's a really important section. And then at the bottom of the first page is the clinical recommendations for their care and treatment. So, you know, whether we're prioritising extending the life of this individual or prioritising comfort, safety and dignity, or somewhere in between, because obviously as someone moves through their care journey, different things will be suitable for them. And then there is a free text box where the idea would be for the clinician to discuss with the patient, their family, their carers, care providers, it depends who's most involved with them, what might be suitable in an emergency, what may not. So you may see things here such as, you know, would want to go to hospital for antibiotics or would not want to attend hospital again, because, you know, some individuals do not want to go back to hospital, and that's a decision that's really, you know, important for that individual. The bottom section is the resuscitation decision, whether that individual is for resuscitation, is not for resuscitation, or for some modification CPR, which is mainly in paediatric patients under 18. On the second page is in regards to the capacity and consent of the individual. So obviously the aim is that the patient themselves are involved in this discussion. That being said, that's only possible if they have capacity for these discussions, but you know, we know that capacity can be fluctuant, and you know, you want to have that discussion with the patient ideally. However, unfortunately, you know, say an individual had a dementia diagnosis or something else that limited their capacity, they wouldn't be able to be involved, and then the next, you know, best thing would be to involve their family, carers, friends, whoever is there involved in their life. So it is documented on the form about their involvement in making the plan and their capacity. So that's a really important section. And we do have examples of plans if people would like to take them away to have further look. The clinician then signs the plan. They need to have professional registration number. So it may not be a doctor necessarily, it may be an advanced nurse practitioner, a nurse, a paramedic, whoever has relevant training and respect. It's also preferable that people involved in the plan are documented, so that might be a carer or a relative, and if possible they can sign the plan, but that bit is optional. But it's always important to record an emergency contact because they should be aware of these plans. And then the bottom section is about review. So that's just to give a brief overview, and then pass to Lucy.
So I'll just give you an overview of what happened in Sheffield to adopt the respect process. So the work started in 2022 and there was a project team around that established, and they worked with all these organisations that you can see here to develop a citywide policy that you can read. It's available on the Health and Care Partnership website. And Sheffield aren't alone in using respect. Hannah already mentioned it's 80% of counties in the UK, and that includes South Yorkshire, Doncaster, Barnsley and Rotherham, and also other local areas such as Derbyshire. Next slide, please. So there was a lot of work that's gone into this over the last 2 years. The project team have engaged with patient panels there. They've worked in operational groups to engage those clinical leads and organisational leads. There's been a lot of work with primary care, engaging locality managers. They worked with organisations to develop comms and toolkits to raise awareness with all the employees of these organisations that have adopted respect. And that includes YAS, Yorkshire Ambulance Services. And there is a meeting structure in place. So there's a delivery group and at the moment an audit group. So they have been monthly meetings for these clinical leads in the organisations, and that will continue for the next 12 months or so in a slightly reduced format. So these organisations still meet together to discuss how respect is being rolled out in their organisations. And after the launch, which was in May last year, all organisations, they've had some form of training. Most of that is mandatory. We've been supporting them with information resources to support their staff training. There's also been ECHO programmes which St Luke's have supported on. So ECHO is a learning programme that uses case-based examples, and they've been for care home staff, and there's going to be a regional ECHO programme that looks at respect with different healthcare, so respect and respiratory conditions, respect and frailty, for example. And we've been working on some engagement with public and voluntary groups who might have direct involvement with patients, such as social prescribers or those working with hospital admissions. Next slide, please. So if you would like more information, there is the Health and Care Partnership website, and that has patient information, it has information for clinicians, easy read formats, for example, and that's where the citywide policy is. There's also the Resource Council, which has national information, and those are the training modules which are aimed at healthcare professionals, but the Tier 1 is a short animated video that looks at the patient journey from having a respect conversation to an emergency situation. So if you wanted some more awareness of respect, that's a good resource for people in your professions. And we did bring some example plans if anyone would like to have a look at them. I think that's the end of our slides. Thank you.
Just going to ask you to directly address Mr. Berry's case study that he's brought, if you like, if we look at it like that. So I think the question really is how someone's come home from hospital with a respect plan without any family or carers being involved in that.
Yes, yes. I mean, obviously it's difficult to know the exact circumstances around the individual case and things. I don't know if it's someone personal to you. Obviously it's not best practice at all to not have an individual, the patient or their families be aware of a respect plan, and it's disappointing to learn that that was the case. As we discussed, you know, they should always be involved, always be aware. I mean, in terms of respect plans and the resuscitation system, it is a medical decision. However, it should be a medical decision in collaboration with the individual, ideally, or their friends and family. And that should be documented. So, yes, what happened in that case is sort of, it doesn't sound ideal. There is the Patient Advisory and Liaison Service at STH, if that was, you mentioned it was from STH, that I would maybe encourage the individual involved to, or their family to approach to learn more about what happened, because I know that, you know, we want feedback from patients and families.
Yeah, thank you for replying. It's been helpful in enlightening us about the process, how it should happen. There's obviously been something that didn't happen at this stage, in that the DNR process was still being used in Sheffield up until, well, this was around about October time last year. So the implementation and training obviously hasn't been addressed as well as it could be. I suppose I'm just where the accountability for the respect plan lie, because you say it can be issued by the ambulance service, it can be issued by nursing staff, it can be issued by clinicians. So it's just about where is the accountability for that plan, and how is it then reviewed as people go through the patient chain?
So yes, so the plans can be formulated in sort of different healthcare settings. It may be when they're an inpatient in the trust or when they're in the community, by anyone who has relevant training and respect. The plan then remains with, the ideas plan remains with the individual on their person. There is a paper copy. We are trying to encourage electronic copies to be kept, but the most valid plan is the one with the individual. Then if they changed settings, for example, and went, say, to a nursing home from home, they would take the plan with them. The idea would then be that the plan was reviewed, and if it remained valid, it could remain valid. However, as things changed, say someone became more frail or deteriorated, and their needs and wishes changed, they would need a new plan formulating. So it may be that an individual does have a number of respect plans over their healthcare journey. In terms of accountability, it's the individual that has documented the plan. I would say that they sign the plan to say that that's valid at that point, and then it remains with the patient. I hope that answers the question.
Thank you. So in the work that Health Watch did on end-of-life care very recently, we heard some stories that I think kind of reflect the story that you've shared today. So I would sort of hazard a guess that sadly it's not a lone example, unfortunately. And whilst lots of the stories that we heard, they weren't all about the respect process, because we were talking to people about experiences over the last sort of couple of years. So some of them will have related to DNR forms rather than respect. But I think that when I looked at the form, one thing that struck me was, and I know that you're limited by the form, you can't invent your own form because it's a set form, but it is a very sort of binary option. You've either sort of ticking I've involved the person, or you've sort of ticked they haven't got capacity and I have involved relevant people. One of the sort of specific bits of feedback that we got was that even where people had been taken through a process as an individual with capacity, that later they reflected that that would have happened much better if they'd had the opportunity to spend more time thinking and talking about it with friends and family. So I suppose I'm just sort of suggesting, or I don't know how much already is sort of contained in the training to sort of emphasise the importance of that conversation happening in a way that properly involves people at the right time, and also that people are given a chance to reflect. So I also wondered, and I didn't sort of get a chance to sort of scan every bit of the form, but if is there a place on the form that directs people to sort of what they can do if at a later date they've got specific questions or they want to kind of revisit the form? So, you know, in the example we've heard today, if there'd have been an attached bit of paper that said, actually, you know, if you've got any follow-up questions or want to revisit this discussion, this is how you go about it. I think that would be something that would be really valuable to people. But I do appreciate that this is a set process and it's not something that you've invented yourself.
Just to respond to that, Lucy, I think there's some great ideas there. So yes, we will definitely do that. This isn't the end of the journey. What I would say, and this is not an excuse, but within the trust particularly, change takes quite a long time to embed. And what the trust have said to us is that it could take up to 2 years to fully embed this process in. There are over 10,000 employees that work within this organisation. 15,000 to correct myself here, Jane, thank you. So that's not ideal, but it's a phasing out and a phasing in. We do know and we do monitor the number of members and clinicians that have been trained in the process, and that is increasing and will continue to increase. And we're continuing to offer training. It is part of the primary care training that we're doing over the next few weeks. It's part of the training that's happening on respiratory today. So it's not the end of the process, and you don't just have one piece of training and it stops. And in relation to the audit is taking place. Part of the process is to audit how effectively that is working, and that includes what the processes it is, as well as just auditing the standards against the actual form itself. And that will inform future training as well. So there shouldn't be any new DNA CPR forms being produced, but we do know that they are there, and we are monitoring the data, and we're trying to phase that out and address issues as they're popping up, and that's why the delivery group's there.
Councillor Rooney.
Thank you. This is a really, really difficult subject to talk about, because at the end of the day we're talking about potentially ending someone's life by not responding medically to a particular situation. And the thing that I struggle, well, there's a number of things I struggle with. One is, I just think that the outcome of the discussion might be different depending on where that discussion takes place. So if it's done in the calm of your own home, when you are feeling reasonably well and not in crisis in the back of an ambulance with the blue light going, nah, 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 then I think you might get two different outcomes to the conversation. And that does worry me, that whether or not the conversations with the individuals concerned are taking place in an atmosphere that almost points you in a particular direction, particularly the blue light one. I mean, I've had that myself recently. Well, not that recently, about 15 months ago. So the other is about who decides, who has the final decision. Is it going to be the person concerned, because if it was me, I would want it with me to make that decision, not somebody, maybe my family, depending on how ill I was or wasn't, but I personally would like to make that decision myself, not a complete stranger who the doctor would be. So are there rules about who does or does not take the decision, the final decision? As I said, those are the two things that concern me the most, the final decision, because it almost feels like it's an assisted suicide in some ways. You know, you've got somebody who's very, very unwell and may not have any sort of quality of life as a result of what's just happened to them. And then somebody decides, well, actually, it's the best thing if you die, because you're going to be, you know, your life isn't going to be worth living. But I do genuinely think that the outcome of the conversation will be completely different depending on where in what environment it takes place. Thank you.
Yes, so I think I absolutely agree. I think the context of the conversation is really important, because if someone's got an acute hospital admission, they're in A&E, for example, it's completely different to if they're at home. And I think, you know, that these plans will be formulated in different care settings, but I think it's a process. It should be a process, as you mentioned. You know, patients and individuals should have time. I always say that to my patients when I start these discussions, even if it is in their own home, that, you know, they don't have to make any decisions there. They should think about it, and I can then come back and we can formulate the plan together. Obviously, that's an ideal. It doesn't always happen if someone is rushed into A&E, blue lighted and things. But I think that's also why these plans should be reviewed in any change of care setting or health setting. And so they're not a final say. As we said, they're not legally binding, they're just recommendations. In terms of your other point in regards to you know, who has the final say, it should be a collaborative approach, these things. It is the clinician who signs the form and makes the recommendation, so I guess the responsibility does lie with them. And that works both ways as well, because, you know, I often think of it of taking that responsibility away from families. You know, it's extremely distressing for a family to make a decision in regards to resuscitation or other care preferences. You know, you often hear people say they were asked to sign a DNA CPR form when they were being used, or a respect plan. And that isn't the case, that, you know, they don't actually, that they sign in the respect plan about their involvement, but it's not that we're asking them to make that decision, we're not putting that on them. So it does lie with the clinician, however it should be with discussion with the patient and their families. And if a decision is made that the individual is not to be for resuscitation, that's not to say that an individual won't have any all other care provisions. So they would still be, if they wish to be, they would still be treated for infections. I think that's often maybe a misunderstanding, that people think that, you know, nothing else is going to be done for the individual if that decision made. The resuscitation is if an individual's heart stopped of natural causes at the end of their life, that an attempt wouldn't be made to restart it, rather than any other care. I hope that clarifies a little bit. Thanks.
Thank you. And just for transparency, Mr. Berry is a neighbour of mine, but the case study in question is someone that's not known to me. Just thought I ought to mention that. I was just going back to that sort of case study, and what you were saying about the respect plan's been fairly recently a new thing for Sheffield since May last year. I just wondered what the plans were for sort of reviewing their implementation and like monitoring whether anyone has made a complaint about the plans themselves or how they've been put together. I just wondered if there was a plan for that, and then maybe to the committee in light of that, whether it's something we'd like to look at again in the future, bring back to the committee. Thank you.
So at the moment we're working on an audit, which is all organisations that have signed up to adopt are auditing within their organisation, and they're going to submit that to us, the citywide project team, and that goes to the Resuscitation Council. So this is the first audit of respect plans, and we're going to use that to set the benchmarks for what the future audits might look at for those plans. And I think our recommendation is that organisations before would have had a DNA CPR audit as part of their processes. So this would replace that previous audit that they would be conducting. So it is very new, and we will learn a lot in the next 2 months, because that's when we're pulling the audit together. And I think in terms of looking at complaints as well, there are services in each organisation, like the PALs that we've referenced. So we can certainly look at how those are better used to look at things that are coming in about respect. If you have anything to add, Louise.
Yeah, just to add to that, we are working with the ICB quality team to make sure that the NHS standard contract contains respect as part of the audit process within each of the organisations that are commissioned that have that contract. So that would be on an ongoing basis on the back of the audit that comes through. And the aim is that this audit will show us how we are performing against the standards that the Research Council have set nationally for everyone. And that will be the benchmark to improve the performance going forward. Yeah.
Can I just ask, is a patient able to initiate a review to their respect? And is a patient who currently has a DNA CPR form in place able to initiate a change to a respect, to have a respect form in place instead? And are patients being proactively informed about the switch to respect if they've got a current DNA CPR in place? Or are you worried about capacity if you suddenly get a flood of people wanting to change over to respect? I mean, that's nothing to be embarrassed about if that's the reality. They haven't got the capacity isn't there to deal with it. I'm just interested from the patient's point of view, how agile the system is in terms of wanting to make a change or get onto respect rather than the old form.
Yes, yes, we definitely encourage patients to approach their GP or whoever it might be to initiate a respect discussion. That would be fantastic if that happened. And, we're trying to increase knowledge. There's lots of patient leaflets around respect. Went to the carers ratio, lots of different ways of trying to increase awareness of it. There will be lots of DNA CPR forms still in circulation whilst the transition happens. It's a process and it will take time. But yes, certainly if a patient wanted to switch, so they had a more comprehensive care plan, absolutely. And I always think of it, in my practice, for example, I will try and replace all DNA CPR forms to respect, but it's often if you go and see them for a home visit or something changes, and that's a really good point at which to do this, but it will take time. But we're seeing the numbers go up. Our last figures were there was about 1,800 respect plans in Sheffield, which is great, and there may even be more than that in circulation.
Clearly this looks a sort of better process than we had before with the DNR, because I think I know when my mother was in the last stages of her life and was admitted into hospital, and I felt pressurised in signing a DNR. She had Alzheimer's, and in a very short space of time I'd had 3 doctors ask me about it. And I did, although I understood that it was just if she had a heart attack they wouldn't resuscitate, I did feel as if I was being asked to make that decision to kill my mother, and it is a very difficult time to make a decision like that. And I think we've spoken about the fact that it's a very difficult topic, and it's a topic that you're only discussing when you're at that really vulnerable stage of your life, isn't it? But how we go about that, I don't know. I also have concerns that when you're saying that the form can be filled in, whether it's in the ambulance or it's, your GPs and the whole raft of professionals who can do that, are we then going to get the sort of joined up, where it all comes together? That's my concern. And I think it's a really valid point that Lucy made. There should be somewhere on the form that says, whether it's a phone number or somewhere to write to, or whatever, that if you have any issues with this form, any changes you want to make, or whether it says see your GP or whoever, there should be something so that people know that they've got that form, and if there's ever anything wrong with it, or they want to change things, that they've got that recourse to do that. And I think that would be a really, really good idea. Yeah, thank you.
Just before you respond to that, I'm just going to ask, just hear the clock. Members happy to extend the meeting by up to a quarter of an hour just so we can finish our discussion off.
I know that the teaching hospitals, their plan has a patient information attached to it, but it's the Resource Council that developed the plan itself, and we can feed back to them that perhaps something on the bottom of it that says who you can go to if for any reason they're not given a patient information leaflet to accompany it, so we can make that recommendation.
And I think in primary care that would be useful as well if we do recommend that they do give information, but not just the plan. I think that's a really good way. In terms of tying everything up together, I think, hopefully the plan should be with the individual, and the idea is that it would be kept electronically, so that the plans, that there's not duplicates and things like that. But it's something we're working on.
Can I? Yeah. Just to add to that, there is no electronic version nationally, which is not ideal. But what we are doing, just to refer back to the strategy, includes a priority around IT development. And one of the things that we are doing and want to do is get on palliative and end-of-life care on a list of IT projects. And that's what we're trying to do, and we want to raise the profile of trying to get a respect to electronic. It's not a quick fix solution, IT problem solutions never are, but we're trying to raise the profile. In terms of who and when you should have the conversation is a really difficult thing. The respect process is not a palliative and end-of-life care process, actually, but it's one way of raising the profile. And that's why we're here today talking about respect, and that's why it's part of the palliative and end-of-life care strategy. But actually it's part of long-term conditions. And as soon as you get identified with a long-term condition, it's actually the best time to start talking about and implementing this process, so it doesn't end up being just about DNA CPR, and actually is a broader informed discussion that can be taken, if need be, over a period of time. So we are at the start of that process, and so my interest is from a palliative and end-of-life care perspective, but as a wider team we're trying to do that. So for example, today there is respect training in relation to respiratory. So it's, if you've got a respiratory problem, how should we start that respect training? So the training that we're going to be doing South Yorkshire wide, that has started today, is about starting those conversations earlier. So if you're working with someone that's got dementia, how and when is that the best approach to take, and is it over 2 or 3 occasions? When I promoted it within the homeless sector, it was, we need to talk about how you advocate for that person along that journey, and it's not just about having that conversation once. It might be over 2 or 3 kind of sessions when that person may or may not be has got that capacity and is not fluctuates, because they have tendencies to fluctuate. So it's about having the conversation at the right time. What we have as a system where we've tried to educate lots of people, and we're continuing to do that, and we know there's lots more to do, but what we need to do is get the feedback from the audit that is then going to build on that intelligence and continue to kind of come up with the training plan to kind of try and get those conversations earlier. So hopefully that responds a little bit and addresses some of the concerns. I don't want to sound like I've got all the answers, because I haven't, so hearing what you're saying here today is just helping inform and giving us the support we need to kind of say, yes, we need to take this and continue to press this way forward. In relation to where it is on our priorities as an ICB, it is on our forward plan, and we are continuing to have it on our forward plan.
Can I just come back?
I'm just going to...
Oh, sorry.
Is it really important? And I'm just aware we haven't really had any questions about the fuller palliative and end of life. Just want to make sure members have got a chance for that. I'm going to be really rude and jump in with my own comment, and then it's all yours. Just going back to the just to bring our focus back to the palliative and end of life care strategy. I just want to comment that I think in some respects and looking at the research pack that Healthwatch put together to inform the strategy, some of it is starting from a really low point, and I think it's obviously it's a shame, but it's really good that it's been identified, and thanking Healthwatch for the thorough work that they did in that. But some of it is quite a low point. Some of the stats in how satisfied people are and how cared for they feel are very, very low, in the 30s%, you know, and I think what I've perceived looking at it all is that the further you move away from acute hospital, the less satisfaction there is with the care provision, accessibility, communication between different services, and so on. So it seems to me that it's been perhaps a very medical-led kind of model, and the further away you get from that acute medical setting, the worse it gets for people in their experience. That's my perception from reading the evidence that's being produced. And I would say, as a reflection of that, I think it's really, really important in bringing this strategy to an agreement point in February, as you've proposed, that actually it shouldn't be fully owned by the ICB, this strategy. I feel like it needs to be co-owned by other partners that are other parts of the system. And I don't see that currently how it's sitting now. It looks very owned by the ICB, and I think it would be much more helpful as a citywide and South Yorkshire-wide. Obviously, we're looking at it from a Sheffield perspective today. But to see equal partnerships in that and co-ownership of the strategy. So I wonder whether it needs to be taken away before you go to that sort of plan sign-off and moving into an action plan, whether it just needs a bit more work to get that co-ownership and a broader kind of sense of, you know, the council in terms of social care, voluntary organisations, the hospices, all being part of the co-creation of that plan, rather than it being something that the ICB has produced with reference to those organisations. Do you see the slight...
In terms of the bereavement funding, whose ears do we need to be bending as politicians to try and get that position reversed? Who's holding the purse strings at the moment?
In relation to the bereavement, ideally we would like to get money from the ICB and from Public Health in Sheffield City Council, which is where the money came from before.
Okay.
And
how much are we talking?
It's
200.
It's about £250,000.
That's peanuts in
roughly. I would have to add it up again, but yes.
The other point I wanted to make was when I used to sit in the chair that Ruth is now in. Some years ago, we actually held a meeting of this committee at St Luke's, and I was shocked to find how precarious their funding is. And I'm just wondering where they are now, because they are an integral part of the service in this city. Without them, we would only have a much reduced service. And I'm just wondering if we could have a discussion or a paper or something that explains where they are financially at this time. So I don't know, because without them, we wouldn't have a proper service.
It's a mystery to me why hospices aren't funded by the NHS, but there we are.
But it's like the lifeboat services. I can't get my head around that not being a blue light service.
Can I respond on a few things, please, briefly? St Luke's are producing their own strategy at the moment, so you will have the opportunity to look at that, and that does include their financial situation and their ongoing sustainability. We do fund the hospice, but we're not their only funder, because obviously a lot of their funding is from the public. Our strategy has been developed with input from the hospices and from social care and from all of the people who came to our stakeholder day. So it isn't just that it's written for us, and when we have the final version, it will have the logos on of all the organisations. But I think I like that idea of ownership and partnership. I think that should come through much more clearly. And what you were saying about patient satisfaction, obviously not everyone who's died or lost someone responded to the Health Watch survey. They were a small subset of how many people die every week in Sheffield?
About 80 people.
About 80 people. What we do know, though, is that people are often very satisfied with the care they receive at home and the care they receive from the hospice and the care from their GP. It's the bits in between that people find difficult. People will say, it's very tiring to be the glue between services. Each individual service might be great, but I'm having to spend a lot of time on the phone. Those are the things that really are frustrating. And just, I really liked your suggestion about the workshop, and I feel like I would be really remiss if I didn't recommend or suggest to you that you also invited our partners in Compassionate Sheffield. I don't know how much you know about Compassionate Sheffield, but obviously they are funded by the council and by the ICB and hosted at St Luke's. And they're a really important part of what Councillor Thornton was talking about when she was saying difficult to talk about it because we're not very good at talking about this stuff. That's their whole raison d'etre, to provide opportunities for people to think and talk about this stuff. And I'm hoping that, you know, the work that they're doing on advanced care planning, etc., will make it easier for communities that traditionally have found it hard to think about these things, or maybe even taboo, that they can enter into that. And then when the time comes for them maybe to have a respect conversation or a conversation about their desires and wishes for the end of life, it'll be much easier because of the work that Compassionate Sheffield have done. So I just wanted to give them a plug. I would feel very remiss if I didn't. Thank you.
I just wanted to pick up on the question that Mr Berry asked about personal, the budgets, the personal health budgets, which is a really interesting point actually, because I'm not familiar with sort of the evidence that you're describing. When we did our work, actually, the opposite came out, in that when we were, but in a small way, so there may well be a kind of wealth of, you know, alternative information out there. So when we spoke particularly to people in the African Caribbean community, or when SACMA spoke to those people on behalf of the project that we were doing, one of the kind of positives that came out were people felt they had been really well cared for, where they were able to access social care, personal budgets, direct payments to get the care they needed at home, because they were able to get culturally appropriate care that supported their needs in that way. I think the kind of caveat to that was that it worked because they had a charity that supported that and enabled it to happen, even though the charity themselves weren't funded particularly to do that work, but they formed the glue, if you like, to sort of set that up and to sort of keep the show on the road. So I guess I was just interested really to sort of think about, or to ask a question about what your sort of thoughts are on personal health budgets. I'm assuming you're thinking in terms of maybe continuing healthcare funding, or sort of where that's come from and what the sort of driver for that is and what it might look like.
It's something that's on our radar to explore, because it's something that in Sheffield we haven't really done very much about. And we know that particularly for younger people, if they can't be cared for at home, the thought of going into a care home is alarming, because we don't have residential care that's suitable for maybe people in their 40s and 50s who may have very complex needs that can't be cared for at home in the normal menu of health and social care. And that's where continuing healthcare and personal health budgets might be really important in terms of equipment and adaptations and care, because we want people to be able to live their life right up until the moment that they die. And if they can't get out of the house easily to access some leisure opportunity, then they're not living their life, whereas a personal health budget might enable them to do that. So that is on our kind of shopping list of things that we really want to do some thinking about, and listening to what's happening elsewhere in the country, good practice, or what the evidence actually says.
Mr. Berry would like to comment back.
Just to respond to that, it always seems like a very nice idea to have a personal budget, because it always suggests that that budget is going to be big enough for everything you want. But all the evidence shows is that personalised budgets show a shrinking statutory level, and then you either have to supplement it by charitable donations or buy from your own private purse. So actually it exacerbates inequalities rather than ending them.
I think we probably need to draw a line on our discussion for time reasons. I note there's a form that's been linked in the report for members to give their feedback. So rather than trying to craft a collated feedback, I think if individual members of the subcommittee can use that form, which is linked, I think, on the last page of the end-of-life care part of the report. And the deadline is tomorrow. Tomorrow, but privately until Monday. Okay, so if that's your email address, isn't there, Louise, and a link. So if members can just undertake to put your own feedback from the discussions we've had today, and that will be helpful to inform you, won't it, going forward? Okay.
Louise's email address is at the end of the report.
It's at the end of the end-of-life part of the report, is it?
It's the end of the complete
The end of the whole report. So if you can't find it, just let us know. Okay. Thank you very much for your time. I think there's more conversation to be had down the line, so I think we'll probably be in touch about how we might want to continue some of this conversation a bit further on. But thank you for today. Members, we just have to quickly agree the work programme going forward, which is... Page 43 in your packed work programme, so we're just looking ahead to the remainder of this year. Are there any comments about the items coming up?
Chair, could I just say that it's not in the, obviously the list of potential workshop titles are in there. You will all have received just before Christmas a set of provisional dates for workshops, and it's really just a case of how many of those I can marry up to the workshops that are listed in the work programme between now and the end of the year. The rest will roll over, but hopefully we're going to have a workshop in February on dentistry. And I'm also going to be completing, hopefully this afternoon, a questionnaire that I would really appreciate if members have got any comments on that. I'll send it in draft. If you could get comments back to me as quickly as possible, then I can put that on our Have Your Say website. And so we should have some feedback in advance of the workshop that we can use to inform discussions.
Any comments on the work programme? We've got our meeting in March. There's 3 items down for that. Content services, relocation, step-down services, that's an update. And adult autism and neurodevelopment pathways, that's not something we've had before, is it?
No.
Any comments? I mean, feed them back by email after today if you've got any reflections on those. And keep an eye out for workshop dates, and we'll pick up the rest of the bereavement services conversation. Sophie, if you want to put any input into how you might want that discussion to be framed, just let me know. Okay. Good. Thank you, everyone, for your time and all your questions today, and see you next time.